Hi, this is Mike McCarter, your EMS System Coordinator, with an update to the Quincy Area EMS Protocol AP1 Needle Chest Decompression. Tension pneumothorax is a life-threatening emergency, and it's crucial to be able to decompress the chest to help restore adequate ventilation and perfusion. In this emergency, air is being forced into the pleural space, collapsing the affected lung. As pressure increases in that space, the mediastinum is displaced to the opposite side. This kinks the vena cava, which leads to less blood returning to the heart and ultimately to shock. Three key findings should be present to indicate a tension pneumothorax. 1, evidence that the patient's respiratory distress is worsening, or if you are ventilating the patient with a bag valve device, it becomes more difficult to bag. 2, breath sounds on the affected side will be diminished or absent. And 3, the patient will be in shock. You might also note jugular vein distension or tracheal deviation, but those are late findings. Contraindications to performing this procedure include a simple pneumothorax, which is not causing shock and does not require decompression, or an open pneumothorax that has been closed off with an occlusive dressing. In that case, release the occlusive dressing to allow air to escape. If that does not work, go ahead with the needle decompression. Now let's move on to the part of the protocol that has changed. Both ATLS and PHTLS have made the recommendation to perform needle decompression at the 5th intercostal space, anterior axillary line, using a large bore catheter at least 8 centimeters in length. A 14 gauge or larger is recommended. The advantages of the 5th intercostal space anterior axillary line are the relative safety compared to the 2nd intercostal space, making it less likely to hit a subclavian vessel, mammary artery, or the heart. Also, the chest wall is thinner across all body mass index quartiles in both males and females at the 5th ICS-AAL. Third, a higher rate of the catheter successfully entering the pleural cavity has been demonstrated on cadavers. And lastly, it's been found to be dislodged less frequently, although there has been a higher incidence of the catheter becoming kinked. To recap, the main change to the protocol is the preferred location for the decompression, which is now the 5th intercostal space, anterior axillary line. The 2nd intercostal space, midclavicular line, is still an option if some type of trauma would prevent using the 5th intercostal space. First, locate the anterior axillary line. Then, locate the 5th intercostal space, anterior axillary line. As a reference point, think of the location of V5 when you're performing a 12-lead ECG, but make sure that you're on the side that is demonstrating the tension pneumo. Cleanse the site thoroughly. Now insert the needle. Be sure that you are inserting the needle just over the top of the 6th rib in order to avoid the bundle of artery, vein, and nerve that sits just below each rib. Remove the stylet. You should hear a rush of air. Tape the catheter in place and reassess the patient for improvement in ventilation and perfusion. Monitor the site during movement and transport to prevent kinking of the catheter. If the patient starts to improve but once again worsens and continues to have signs and symptoms of tension pneumothorax, a 2nd catheter can be inserted next to the 1st. The revised protocol is due to be implemented December 15th, 2019. Your agency leader will set up a time for you to practice this skill on the mannequin, or you can contact the EMS department for a practice time.